All right, now we've got it recording. Thank you for reminding me of that. Caption should be enabled, but it will also turn on when we, when we start the presentation. All right, there we go. Thank you for those reminders. All right, so where we're headed is getting into disordered behaviors. And like I said, the treatments can be of a physical nature, such as medication, or even surgery, or some type of electrical convulsive type of stimulation. Those types of things can be psychological. It could be counseling, therapy, psychotherapy, and it can also be social, such as support groups and those types of things. And as we go through these different disorders, we will talk about each of these therapies, but I want everyone to keep in mind, we're going to talk about psychotherapy as something separate from medical therapy. But what we know is it's the combination of these two that make people successfully treat their symptoms. And I'll also say, again, going to physical disorders, we know that people are more likely to rehabilitate from cancer by having a cancer treatment, and also going to therapy or a support group for cancer survivors. So we'll see that, again, even though we talk about these separately, they're very much in the same categories as we move forward, okay? So I'm going to share my screen. And the first thing I'm going to do is I just want to give us a reminder of how we define disordered behavior. So let's talk about that. So again, when we talk about a mental disorder, or AKA psychological disorder, behavioral disorder, whichever terminology that you use, we need to remember that it's a cluster of abnormal behaviors. So it's not just being sad, as an example, but it's being sad in association with sleep issues, in association with maybe even eating issues and all. And so it's a cluster of behaviors, okay? And these clusters of behaviors need to have three qualities. One, they need to be deviant, meaning that when we say they're deviant, it's because they take place in most domains of life, okay? So as an example, I'll use the example of depression. If you're only depressed when you're at work, but you don't have any symptoms when you're at home, then it's probably your work setting that is bringing about those symptoms, but it's not necessarily a disorder that's driving it. So when we talk about deviant behavior, we mean that those abnormal behaviors are within most domains of our life, including our home life, our work life, our religious life, our social lives. They're constantly there with the individual. The second thing is that these symptoms are distressful, meaning that they're causing the individual some type of distress and concern. They recognize that their behaviors are maladaptive and are not helpful to them. And it also can mean it's distressful to people around them, because there are certain disorders, especially in childhood, that are not necessarily distressful to the child or the adolescent, but are distressful to the family and school systems. So we'll talk about that when we get into more of the developmental disorders and those kinds of things as we move over time. The third quality of a disorder is that it's persistent over time, okay? Meaning that the symptoms are recognizable for most days of the week, and that they persist more than 6 to 8 weeks, okay? And it has to be consistent in those 6 to 8 weeks. Again, when we see a breakup of symptoms, so maybe it's depressive symptoms on Monday and Wednesday, it might be because you don't have any of my classes on those days, and that's depressed. No, I'm kidding. That's a joke. It may be something about things that have to happen during those days that are causing those symptoms. Much like, again, I'll relate it back to physical symptoms. There's certain things we don't do on certain days, and it causes our bodies to not be as productive and fulfilling as it usually is, okay? So the persistence over time is important. The other reason persistence over time is important, because we all have life events that are very distressful, such as a loss of a job, a loss of a loved one, a car wreck, things like that, that can cause symptomologies of a disorder, but they will go away over time for the most part. We'll get to some disorders that individuals may need more intervention with, but for the most part, most people who, for example, experience depression, the depression will go away within about 90 days. But again, if we have those other qualities, the deviant and distressful, that's when we need to put a check on it. It says most important here, and it really is important, and it's the notion that the behaviors need to be maladaptive. Maladaptive in that they prevent the individual from doing normal life stuff, like getting up in the morning, going to work, being productive at work, maintaining good social relationships. If you're a parent, being able to parent your children, and those kinds of things. So when we talk about the disordered behavior has to be maladaptive, we're talking about how it interrupts the person from being able to live what you would consider a normal, regular life and be engaged in life, okay? So that's our working definition. Now, I mentioned it would be good to review the information on the Diagnostics and Statistical Manual. We call it from the DSM from here on out. We're on the 5th edition, and this is just a list of samples of different disorders that are listed in here, and we'll pretty much hit most all of these through our talk over the next several weeks, maybe the next month or so. But what the DSM is it's the Diagnostic Manual. It is published by the American Psychiatric Association. And what it does is it tries to differentiate between different disordered behaviors, okay? Now we're on the 5th edition, and this is an important thing to note about how things have changed over the years. In the original DSMs, there was a lot more different types of disorders, and they were very categorical, okay? The biggest change with the DSM, and everyone has probably heard the word spectrum, that, autism spectrum disorder or depression on a spectrum, okay? What the DSM has done in the DSM-5 is it's put these disorders from mild disturbance to severe disturbance based on the functioning of the individual within that. So instead of just saying you have mild, instead of just saying you have clinical depression, we can say something like you have depression and this is where you are on the scale from mild to severe, and we'll base recommendations for treatment based on where the person lies on that spectrum. Probably the most common one that has been talked about a lot lately is autism and the autistic spectrum, because what they did with the DSM-5 is they combined a couple disorders into the autism diagnosis. because they recognized that, and we'll get to these, they recognized that these disorders were so similar that they were more related with each other. One example is Asperger's disorder, which is what now is considered a mild to moderate version of autism, which we will get to here in just a few minutes. The other thing that the DSM-5 does is it has taken out some social disorders that in the DSM-4 and below were considered psychological or mental disorders, such as homosexuality was taken out of the DSM-5. And DSM-4, I should say that too. It was taken out in 1999. So a lot of social disorders, disorders that society thinks people have had in the past, have also been removed from the DSM as well. So what we're dealing with this manual is disorders that are set on a continuum or a spectrum, and they're more refined in the nature that they've tried to take out whether society thinks it's a disorder or not, and whether it's actually something that meets all of those criteria that I mentioned before. But to simplify what we're going to talk about with disorders, we're going to put them into 4 categories. And we're going to originally kind of look at 2 disorders in each category as examples of each one of these, okay? So the first one that we want to consider is developmental disorders, okay? So when we're talking about developmental disorders, we're talking about disorders that are caused by a disruption in the normal development of an individual, okay? And usually most of these are categorized into childhood, because those are the major areas of development where we're learning the most, we're gaining language, we're gaining knowledge. And so most developmental disorders are categorized within childhood, but we are recognizing as we move forward that these disorders don't necessarily stop in childhood, that we have adults with ADHD, and we have children who are adults who are autistic. And one of the changes I'm going to kind of predict that comes out in the next edition of the DSM is that they're going to put in specific adult diagnostic criteria for each of these developmental disorders. Because they're not well understood, and they're slightly different than how a child experiences these disorders. Some other disorders that can be included in this category are cognitive developmental disorders, neurodevelopmental disorders, and many of those are very biologically based, and we'll get to them as well once we get through these examples, so that we have a good understanding of those. The other 2 types, and I want to differentiate between these 2, is mood disorders and stress-related disorders, okay? Mood disorders are disorders that have a depressive or a manic influence on an individual, meaning that their mood is either dysregulated or their mood is stuck in an abnormal range, whether it be a manic range, meaning very hypervigilant, very active, or a very depressed mood, which is inactivity, loss of motivation, those types of things. Okay, that's on the mood level. So we include, for example, depression and bipolar disorder under these types of disorders. Stress-related disorders are disorders that one is constantly in what kind of a, what is it called? Sympathetic response to the environment. Sympathetic response, meaning that they're in a constant fight or flight mindset, okay? So as an example, a person with anxiety is constantly worried that something is going to happen and something's going wrong, and sometimes the world is falling in on them. So they're in a constant hyper physiological state, okay? Post-traumatic stress disorder is a disorder that is response to traumatic events. The most familiar is individuals who come home from the military who have post-traumatic stress disorder because of things they experienced on the battlefield. But in general, whenever someone has a traumatic event, depending on different factors that they have, there's a 17% chance that you will get PTSD symptoms or the full disorder, okay? Which post-traumatic stress disorder is whenever something that is familiar to that traumatic event triggers a stress response in the individual, okay? And so that's the basic definition of that. So the difference between mood and stress, mood is it's an influence on your affect, okay? Anxiety is it's a constant hypervigilant state and constant worry state, okay? Now you can have both, you can have depression and anxiety, but they do need to be treated as two separate things because you have two separate things going on, okay? And then we have psychotic disorders. Psychotic disorders are those disorders where you have a break from reality. That's the basic definition of a psychotic disorder, is that there's some different version of reality that an individual kind of lives in. We're going to talk about schizophrenia within this domain. Schizophrenia, I think I've described it a couple times. Schizophrenia is where somebody has disorganized thinking. There's notions of extreme paranoia, and there's a different type of hallucinations, whether it be olfactory, auditory, or visual, that are not there within reality. Okay, and then we're going to talk about personality disorders, and the one we're going to focus on in this section is borderline personality disorder. But what is a personality disorder? A personality disorder is a disorder when there's a disruption to an individual's personality, personality being that thing that makes you unique, that makes you who you are, okay? And I mentioned before that there are disorders that do not cause stress to the individuals, but can cause stress to their environment and to those around them. One personality disorder that we will talk about is narcissism or narcissistic personality disorder. This is at a very basic level, is just an extreme love for oneself. And so they exert that to other people and expect other people to recognize them for that, okay? And then one disorder that we're going to focus on is borderline personality disorder. Borderline personality disorder is a disorder of where an individual keeps heading up towards success, and then they spiral down and they become very, very self-destructive, okay? And the reason why I want to look at this disorder is borderline personality disorder is often misdiagnosed as bipolar disorder. But as we will see when we get to the section, bipolar disorder is mainly physiologically driven, meaning that someone with bipolar really needs to be on a medication in order to treat that disorder. Borderline personality disorder is caused by underlying traumas that a person experiences in childhood that the family never recognizes or talks about, okay? They get confused because you see this going up, success, and then you see a downward spiral, down and down and down. Bipolar is a swing between a depressive state and a manic state. And so they often look very similar behaviorally, but their causes are different. And indeed, if you put someone with borderline personality disorder on a bipolar medication, it actually makes them worse, not better. It makes their symptoms much worse. So we'll talk about those two things coming up here in a little while, okay? So these are our 4 categories that we're going to deal with in this kind of introduction into disorders, so that we have an understanding of these 4 categories. Does anybody have any questions right at the moment? Thank you, Michelle. Okay. All right. That should look more normal now, right? Okay. So the first one that we're going to look at is autism spectrum disorder. And I think the best place to start with this is with a video. So I'm going to play this video that kind of goes over the brief introduction of what autism is, and then we can go back to that previous slide and have a discussion about each of those points. So let's take a look at this video that kind of quickly goes over the symptomology of autism.
Hey there, welcome to Life Noggin. A lot of people talk about autism, but not everyone understands what it is. Autism spectrum disorder, or ASD, affects how people communicate with and relate to others. This isn't the same as being shy or not knowing what to say. Most people with autism don't understand some of the basic social conventions that others take for granted. They might have trouble making eye contact, holding a conversation, or recognizing gestures. And over 1/3 of people with ASD are nonverbal, meaning they don't use speech. Along with communication issues, people with autism often like to follow certain patterns or repeated behaviors. Many have a sensitivity to bright light or loud noises, and others have physical problems like trouble walking or picking up small objects. Some have intellectual disabilities, but about half have average or above average IQs. It's also common for people with autism to have a great long-term memory for certain details, and many excel in math, science, music, or art. With such a wide variety of symptoms, no 2 people with ASD are alike. The behaviors vary so much that they used to be classified as different disorders. One was Asperger's syndrome, where people obsess over particular topics, miss nonverbal social cues, and may not understand appropriate social behavior. In 2013, scientists realized that the boundary between Asperger's syndrome and some of the other disorders was fuzzy, so they decided to put them all under one name. This made it easier to diagnose autism, which is important. The younger someone is diagnosed, the earlier they can get help. In fact, many children who have autism will show signs by just 2 years old, including not responding to their name, avoiding eye contact, and flapping their hands or rocking repeatedly. Even though there is no cure for ASD, therapy and medication can help people adjust. Scientists are also doing clinical trials to find other solutions. They've learned that 1 out of every 68 children in the US has the disorder, but they still aren't sure what causes it. Autism is over 4 times more common in boys than girls, and most scientists think genes play a role because it often runs in families. Some people with ASD have abnormal chromosomes, but this can't be the whole story. There are people with the same gene changes who don't have autism. Other possible causes include having older parents, being exposed to high levels of testosterone in the womb, and having complications during pregnancy or birth. It may even have something to do with gut bacteria, since many autistic people have gastrointestinal issues. But most likely it's a combination of many factors. The one thing scientists know for sure is that vaccines do not cause autism. No matter why it happens, ASD is being diagnosed at a higher rate every year. This doesn't mean it's becoming more common. It just means more people are aware of the condition and getting diagnosed early. And awareness is crucial. The more we learn about autism, the more we can understand and relate to those who have it. It's important to note that people with ASD deserve the same respect, fairness, and chances that people without ASD receive. This will help people with ASD adapt and grow in our communities. We've put some resources in the description if you would like to learn more about ASD and figure out what you can do to help. Is there another disorder or any other topic you would like us to?
All right, so that's a quick description of what autism is, and there's just some things that I want to note. In the video, they made it very close. Autism is a social disease, and this is the first thing that we need to understand about autism. Because in the 1990s and before the 1990s, many children who had autism were misdiagnosed as having a developmental disorder, a cognitive disorder, a neuro deficit of some type, and they were treated for those kinds of things within the education system, but never really recovered. Okay, the symptoms we see with autistic children, such as the stemming behaviors, the repetitive behaviors, all of those different things are a consequence of the social situation that they're in. That really, when we look at this, we'll look at different theories of autism, and we'll see that it truly is that the child is so overwhelmed by the social condition that they try to do behaviors, or they do behaviors to handle that stress and that what's going on. So one of the things that we need to recognize is changes since the 1990s. One of the reasons why we've seen an increased rate of diagnosis of autism, as the video said, is people are starting to recognize what it is. Okay. One of the other reasons why we're seeing increases is a change in the diagnostics. Okay. The research and everything has gotten really, really good on autism. So clinicians are recognizing it at a higher rate instead of mistaking it for another disorder. So some of the arguments for and against whether we're seeing huge increases in autism don't hold, in that we have a more toxic environments, we have more this or that. What we're really seeing is that the increased rates are an increase in the recognition of the disorder itself and how it's defined on a spectrum. Okay, so let's go on and look at So what I want to do for this disorder is go over what are the diagnostic criteria, right? And this is very important. You will notice that the very first diagnostic criteria that a child must have is a deficits in social communication and social interaction. And it needs to, as we've talked about with diagnosis of disorders, it needs to be across multiple contexts and currently and by history, meaning that it's been persistent over time. So again, we see that this needs to occur across contexts, at home, at school, on the playground, and it needs to be persistent over time. And the reason why this is important is that when you see autistic symptoms in a child, let's say when they're in the classroom, but not when they're on the playground or when they're at home, there's something about that classroom. And so we shouldn't go in and treat the child, we should go in and treat the teacher. Okay, the teacher is the one that needs to do something to change the environment and her or his or their interaction with the child that is experiencing the symptoms. But when it is occurring in those multiple contexts where the social communication and interaction is in multiple contexts, that's when we get concerned that it's a disorder or a disordered behavior. And so what are some of these social communication and social interactions? So we see deficits in social emotional reciprocity, ranging, for example, and I'll just read these, from abnormal social approach and failure of normal back and forth conversation to reduce sharing interests, emotions, or affect, to failure to initiate and respond to social interactions. So this can range from a range of different situations. Can be where a child has inappropriate social responses to a social situation. So for example, laughing while everybody else is crying, as an example. Or it can be not having any emotional response at all and not being able to understand, like maybe mom is crying to the child, and this is just an example, and the child just sits there almost with an emotionless reaction to the parent. So it can be on that range of interaction. Deficits in nonverbal communication. I'll read this number 2. Deficits in nonverbal communicative behaviors used in social interaction, ranging, for example, the poor integration of verbal and nonverbal communication to abnormalities in eye contact, body language, deficits understanding use and gestures, or the lack of facial expression and nonverbal communication. I kind of provided an example in number 1 for this. This is where either a child has very inappropriate nonverbal reactions. So maybe they get aggressive when aggression isn't a part of the communication process. Or it may be that the child just is very unemotional in their reaction to something that would normally elicit some type of emotional state. And the third one is a deficit in developing, maintaining, and understanding relationships, ranging from, for example, difficulty in adjusting behaviors to suit various social contexts, to difficulty in sharing imaginative play or making friends, to the absence of interest of peers, okay? So this one is very much about adjusting to different social contexts. Many children with autism have to have very consistent environments from day to day, and any disruption in those environments can set off various symptoms that the child may have. And they may also have difficulties in sharing and playing and making friends, or just have a complete absence of interest in having any friends. So it's sometimes that child that is the loner in all the situations, okay? And we'll see, let me see if we have table 2. Okay, we'll look at table 2 because this is, remember that we're going to talk about spectrums. So when we look at table 2, this is what's going to determine at what level of autism, mild, moderate, or severe, that we would place that child in, okay? All right, so in list B, okay, in list B, these are those secondary behaviors that are a result of that social disorder that the child has, or the social disorder that were listed in A. And so these are the symptoms that often get misdiagnosed as ADHD or a developmental disorder or a cognitive type disorder, okay? So this is where we have to be careful. One possibility is that the child has a stereotyped or repetitive movement in use of objects or speech. So it's kind of, the child has to be in a constant same pattern of movement. An insistence of sameness, inflexibility in their routine, highly restricted or fixated interest on abnormal or intense focus on a given certain object, okay? So this can be a complete obsession with a toy car, and they will not play with anything else, and they have an unusual obsession with it. Hyper or hypoactive to sensory input. So what this means is that, let's say we do a flash of light or temperature in the room. Some children with autism will be very hypersensitive and will react to it very quickly and abnormally. Some children will not even recognize changes in the environment. okay? So those are kind of the extremes that we see with children. Most children, when they have a change in temperature or an adverse response, they react, and some do with, many usually do it with surprise, but it's not an intense hyper response, or it's not a response at all. And that's when we start to get concerned. This one is the one that often gets mistaken for ADHD, which is attention deficit hyperactivity disorder, which we will get to next after we're done with this disorder. Okay. Okay, so again, going back to our definition of this disorder, it manifests early in development. They're actually developing diagnostic criteria where children can be diagnosed with autism within the first year of life. I'm actually thinking I'm going to post a research article on that in our Canvas classroom, because traditionally they say that it can't be diagnosed till the age of 2, but we're finding that there are different symptomologies that we can see clear into infancy. And again, remember what we said about distressful and maladaptive. It must have a significant impairment in their social, occupational, other important areas of current functioning. I don't know many 2-year-olds that have an occupation, but you never know. But what they mean by that is in education or school or duties such as chores. So I just think it's funny they use the term occupational. And the other thing is these disturbances are not better explained by things like intellectual disorder or global developmental delays. So that individual mentioned that there's a percentage of children with autism who do have an intellectual disability of some type, but more than 50% of them do not. And a lot of times they have to differentiate, is this autism or is it an intellectual disability? And that's when they get into more neurological types of understandings of delay. So, and sometimes the child ends up with a dual diagnosis of intellectual disability and autism. So they're comorbid. Whenever you hear that word, that's what that means, is 2 disorders that are occurring together. Okay. All right. And so this is how we determine where a child sets on a spectrum. And if you see each of these levels, we have levels 1 through 3. And each of them require a different level of intervention. So in level 1, requiring support, maybe some parent training, and those types of things. In level 2, we're not only going to be training the parent, we're going to be working with the child and probably with the school. We'll have a school interventionist. Require substantial support. We're talking about a situation where the child may need to do some inpatient type treatment, what they're going to need 24/7 observation of some type and significant intervention. So on level 1, without support, deficits of social communication cause noticeable impairment. Okay. And so we usually note that there's a atypical or unsuccessful social overtures. This is the one that the individual mentioned that a disorder was absorbed into this. This is the Asperger's level of disorder, where the individual has more inappropriate responses or fixated responses to social interactions. Okay. We see inflexible behavior and significant interference with functioning in one or more contexts. Okay. When we get to level 2, we see, okay, so here we have social communication. Now we're seeing verbal and nonverbal communication skills being impaired, along with the inability to interact with individuals. And there's a limited initiation of interaction. The other thing that makes level 2 is a marked odd nonverbal communication, meaning that it's just not consistent with the situation. Then what makes this a more difficult one is that the stress and or difficulty changes focus or action, meaning a change in the environment, the child has a very difficult time adjusting to that change. So we're getting to this level where a child feels most comfortable when routine is set and when social interactions tend to be the same. And any deviation from that causes some distress or change in the child's action. Okay. And then when we get to level 3, this is where we get a severe deficit. This one we have marked deficit. So it's there, but the response is moderate in level. Okay. This is also when we start to get things like unintelligible speech or rare initiation of interaction, approaches to meet needs only and respond to only very direct social approaches, okay? When we look at restrictive behaviors, we see an extreme difficulty coping with change. And this is where we see the restricted and repetitive behaviors that mark interference with functioning, meaning children will get into those at the deficit of not eating, not taking care of themselves. And again, we see the issue of difficulty in changing focus or actions, okay? So again, we see a mild to extreme levels as we go along the spectrum. And dependent upon where we could find the child on this spectrum level will determine the amount of intervention. And some people have asked in previous classes, why do we change intervention level because a child has mild symptoms versus severe symptoms? Why can't we treat them all about the same across context? And the reason is that you don't want to over-treat someone and you don't want to under-treat someone. So it's kind of like, for example, when you go and get a medication for diabetes or blood pressure or whatnot, the doctor usually will look at your blood pressure and depending upon where it is, will start with a mild to moderate dose of medication. And then if it doesn't work, they'll up the dosage as you go along. This is the same situation because you don't want to, again, with the hypertension example, you don't want to over medicate the heart, okay? This is the same thing, is you don't want to over treat the child. You want to treat them at the lowest interventionable level possible. And that's kind of the idea behind the spectrum that we have. Okay, I want to end with this conversation dealing with autism for today is the two theories behind what autism is or what is causing these symptoms. The first hypothesis is what's called the broken mirror hypothesis, okay? If you've taken developmental psychology or introduction to psychology, you know something known as mirror neurons, okay? Mirror neurons is when you look or pay attention to another person, the neurons that are firing in their head start to fire in your head. And then we have this mentalizing system where you take that neural information and you start to interpret those individuals' behaviors. And there's a lot of tests to determine both neurological and behavior that determine at what level a child is developing this mirror neuroning approach. And lots of it deal with what's known as theory of mind. Theory of mind is this ability that develops around 24 months of age, where you're able to recognize yourself and you recognize you have a unique personage. And since you have a unique personage, other people must have their own unique personalities, their own unique perspectives, their own unique ideas. So one of the most basic tests for the mirror neuron and theory of mind is you have two children in a room and you have two cups sitting in front of them. And in front of both the children, you take a ball and put it in cup A. Let's do cup A and cup B. You put the ball in cup A, and then you have one child leave the room, okay? In front of the child who is still there, you take the cup in front of them, you take the ball out of cup A and you put it in cup B. And then you ask the child, when the other child comes back, which cup should they look in to find the ball? Well, if the child has theory of mind, they will say, well, the last time that child experienced that ball, it was in cup A. So when they return, they should say it's in cup A, because even though I experienced it going into cup B, most children start to be able to accomplish this task around 24 to 36 months of age. And I will say that there's about 16 different types of these tasks, ranging from nonverbal to verbal. And so we can test this at a much younger age than 2. And we find that most children develop theory of mind around 24 to 36 months of age. Well, autistic children, what they had found and where this theory comes from is about 60% of them fail theory of mind tasks. And then when we do neuroimaging of their brain, they have a weakened mirror neuron system. So the idea is that they don't understand the social context and people's behaviors around them. And that creates inappropriate social interactions and an insecurity about being in social situations. The issue with this theory is that that 40% of autistic children, ranging from mild to severe, do pass the theory of mind test, and they have very medium to strong levels of mirror neuroning when their brains are scanned. So the issue with this hypothesis is, if it was true, we should see it in 100% of children diagnosed with autism, not just 60%. So now there's another theory. And this one is the one that is probably getting the most attention right now, is most individuals through our day, we can censor out sensory information, okay? So for example, when we're driving, there's a lot of road noise, there's a lot of noise going on that we censor out through our sensory systems. In our limbic system and whatnot, we have these filters, okay? Without these filters, our world would look something like this. I want you to imagine yourself being in the middle of a room, and you're in a chair that is constantly vibrating, and that there's flashing lights everywhere. And that in one corner of the room, it's playing country music. In the other corner of the room, it's playing rap music. In another corner of the room, it's playing rock and roll. In another corner, it's playing classical music. And you have no ability to censor this information out. Those filters that you would have to try and control your sensory world are not there. What we're learning more and more about children with autism is that these filters are missing. So they're in that constant world where they're not able to censor sensory information out. So they're at a constant hyper sensation mode. The world is completely overwhelming because all of the sensory information they're experiencing, they can't turn off. Now, with that sensory component going on, if you add the social world onto it, the social interaction world onto it, that becomes just that more intense for that child to deal with, and their world becomes too overwhelming for them to handle. So then you get the social deficits, but then you also get all those secondary symptoms that we see that are meant to control or try to take control of their sensory world. Okay, this is the leading theory right at the moment, that the filters that allow us to filter out non-necessary sensory information are missing. All right, I'm going to stop here. Stop the